Today we're talking about migraine surgery or headache surgery with Dr. Kassis, who has done more than 500 procedures doing migraine. And I know that's a subject that's very dear to his heart. And I can't wait to learn a lot about migraine, personally as a double board certified plastic surgeon, just to get to know more about it. Tell us, Dr. Kassis.
Yeah, migraine, what we used to call migraine surgery, and now we call it more of a headache surgery, is a subject that is very dear to my heart. Started doing headache surgery in 2018, and over the last 7 years, performed more than 500 surgeries. It's very impactful. People really don't realize how much impact does the headaches and chronic headaches have on patients. What a debilitating disease it is, and knowing that our team was able to help those patients and cure them from their headaches or improve their quality of life significantly was very rewarding and very impactful. It's one of the most rewarding stuff that I do. What is headache surgery? How is that came out? It's good to go a little bit in the history about that. We used to, before year 2000, plastic surgeons used to, before there was all this like Botox and stuff like that, to remove the wrinkles from the forehead, surgeons used to remove those muscles where there are certain nerves, like for example there is called the supraorbital nerve. Those nerves are passing through those muscles, and by removing the muscle you are giving more space for the nerve. And patients used to come and say, it's not only that I look great, but actually my headaches have improved. I used to have headaches and they have improved. So in year 2000, Dr. Gyron looked at all the patients who have done bra lift with decompressing. Like, he wasn't planning to decompress those nerves, but he's taking those muscles and indirectly he was decompressing those nerves, and he found out that a large percentage of those patients, their headaches got better. And this is how migraine surgery started. To answer the question, what is migraine and what are headaches and how they are formed, this is very complex. And to be quite frank with you, we don't really understand 100% how the brain works and how these the different types of headaches we have. There were theories over the years. There was the vascular theory. There were all these things that they keep changing. But we know for sure, what we know for sure is that there is a subset of patients with headaches who have an extracranial cause for their pain. It's not coming from inside their brain. And those patients are the ones that we are able to help with the surgery to get better.
Is that like what this fracture is about?
Yeah.
Exactly, means outside
the brain or inside the brain. So the first differentiation that we see is that the patient, if we want to simplify it, the patients who have pain that's coming from inside their brain, they have what we call as the exploding type of headaches. They feel like as if it's coming from in and out. Those patients, the surgery that I do doesn't help them. But there are the patients where what we call the imploding type of headaches. They feel there is tightness coming from outside in, and those are the patients that are candidates for surgery. So that's in general about those headaches. Patients who have, usually patients who are good candidates, they would know after listening to this. Let's go to the side where are the most common trigger points. So there are, in general, 7 very common trigger points. We'll start with the one in the back. Those are the occipital. So these are the ears, this is the back of the neck. There is a bone here. If you if you feel this is the protuberance there, the occipital protuberance, you feel like it's the end of the skull. Just below it, 3 centimeters below it, there are the greater occipital and the lesser occipital. Those patients will come in and say, every time I have a headache, the back of my neck, I have this spot here that's so tender, and it starts in here and radiates like that to the front. They feel that this pain as if there's an arc coming in from the back to the front and goes behind the eye. It can be on one side, it can be on both sides. So that's the greater occipital, and the lesser occipital, the one in red, is the one to the side of it. It can be a little bit lateral, and we knew over the last 25 years of 26 years of advancing the migraine surgery that a lot of times that side has both the greater and the lesser occipital, and there is another one in the middle called the third occipital. So the first side is the occipital, and we'll talk more in detail in the next video about it. The second side is the temporal. So the temporal, the patients will come in and tell you, every time I have a headache, my pain starts in this area, and there are 2 nerves there. One of them is called the auriculotemporal, and one is called the zygomaticotemporal. Patient will say the pain starts in this area. It feels pulsating headaches as if it's throbbing. If I put sometimes my finger on it, there where there is the vessel, the headaches will get better. And this is the second area or the trigger sites where those headaches start. The third one is above the eye. Those patients will tell you that, like, if I put my finger in here, there is like a little notch in most patients, like a little indentation in the bone where the nerve is passing, the supraorbital and the supratrochlear next to it. I feel that this area is tender, and it always starts there. Same thing. Sometimes they say if I catch it early on and I press on it, I can abort the headache. And there is the other side. The problem is inside the nose. That the patients will have a contact point inside the nose. They have a deviated septum or a hypertrophied turbinate, or they have a contact point inside the nose, and those patients will have pain behind their eye. So these are the sites patients would know that have these headaches, and sometimes patients they never check, and then they will start checking when they have a headache, one of those sites, and they're like, oh my God, this area is so tender. Like if I press on it, like there is a problem in the nerve that is passing in there. So these are the sites. These are the headaches, and who is a candidate? Like we get that all the time. Like am I a candidate? If I'm sitting at home and I want to know if I am a candidate. Candidates for surgery, if you have a headache one time a month, it is most probably, if I were you, I wouldn't be going to surgery. Those headaches have to be severe enough that they are affecting the quality of life. You have been seen by a neurologist, you have tried the medications. Some patients would have tried already Botox, they have tried the nerve blocks, radiofrequency ablation, nerve stimulators. They have tried, you don't have to try all of those to be a candidate for surgery, but at least you need to have been evaluated by a neurologist, and that the medical treatment has failed. If you have a headache and you take a pill and that medication aborts the headache, if I were you, I wouldn't be doing the surgery. The surgery is for patients. There are definitely exceptions. There are patients who are controlled in medication, for example, and they want to get pregnant and they want to stop those medications, and then they will be considering the surgery because some of those medications are not very good with the pregnancy. And there are definitely exceptions, or patients like are taking 6 medications and they are a candidate for surgery, and they say like that can be discussed. But usually it's reserved for patients who have severe enough symptoms that they're affecting their quality of life, patients who have failed medical treatment, and patients who have one of those trigger sites. Those patients are able to identify that trigger site.
That's awesome. So basically they can have it in multiple places, either around the eye or here or in the back area.
Yeah.
And most of the patients that you've done are actually have been on medication that's failed.
That's
why they come
correct.
to you.
They have tried the medications before, and the patients are able to pinpoint. Like if a patient comes in and say, my headaches start in this half of my face, I like try to pinpoint any of those nerves, and they say, no, it doesn't hurt. You know, like I press on this nerve, this nerve, this nerve, and there is no tenderness. Then most probably the etiology of that headache is coming from inside the brain, and we know there are the headaches have multiple different etiologies why they happen that we understand some and some we don't understand. But those patients, if they have a headache from over this side of the head and they cannot pinpoint for a point, most probably their headache is coming from inside the brain and not outside the brain, and they are not candidates for surgery. We don't know the exact number of the total patients with headaches who are candidates for surgery, but we think it's somewhere between 15 and 20% of patients with headaches might have an extracranial cause, which is like what is the extracranial? It's a pinched nerve.
I see.
So all these trigger points will correspond to a nerve, a peripheral nerve, either a branch of the trigeminal nerve, and those patients will have diagnosis of trigeminal neuralgia, for example, or the occipital nerve, which is they will have the diagnosis of occipital neuralgia or cervicogenic headache, or we'll go into more and more details about that in the next video.
So the neurologist, basically, they would have diagnosed them. Let's say they have a headache here, occipital neuralgia. Basically, they would know like this is the pain.
That's correct.
Here. And those patients are actually good candidate for the nerve decompression.
100%. And those patients would have had in the past nerve blocks. They would have had sometimes radiofrequency ablations. The patients would know that their symptoms fit what we are talking about, and sometimes patients. I had some patients that have never checked before, and now they start checking after they see me, and they were like, oh, like they send me like photos over 2 months of where is the headache starting, and they're like, oh, like every time it starts in this area, you know. But the majority of the patients, they would know when they hear this, they would know. Yes, my headache starts above my eye, not in like half of my head, you know.
Have you ever had somebody, let's say somebody listens to this video or watch the video, and then they're like, oh, I think I'm having that. They press on that.
Yeah.
Typical symptoms. It gets worse. It fits kind of what you do. Have you ever had those patients where they kind of come to you directly?
Yes, I have had those patients come into me directly. If they haven't been evaluated by a neurologist, I would send them to a neurologist. I would say, if there is a way that you just have a pill that is going to help you, you should go that route first. If that doesn't work, then we can do the surgery, you know. But most of those patients, their headaches didn't start last year. They have been living with this. They have been struggling with this with years. That's correct.
Most of the times they go the cycle of seeing neurologists, being on medications, trying multiple things, and then they come to you.
And there is a subset of patients who have seen like a neurologist 10 years ago, and they tried all the round of medications. It didn't work. They are sent to pain management. And you know, there is a subset of patients who felt like they're not getting help with medical treatment, and they come in that they're not currently following with a neurologist, but their history would have shown that they have tried all the other stuff. That is correct.
It's like, to me, and knowing more about headache surgery or migraine surgery, talking to you it kind of makes more sense. Let's say if I have it and I know that it's pinch layer, personally, I'd rather go the release kind of. It's like what another surgery, right?
That's correct.
I'd rather go down that route, release it, open that nerve. It's like carpal tunnel, like you were saying. To me, it kind of makes sense. Maybe you think, could it be over the years? Maybe that's how things can potentially shift.
Yeah, that's you see all the spectrum, you know, and most of the patients we see, they have tried already everything, and nothing worked, and this is when they come in. And I have seen patients who had, for example, for the occipital, we'll talk more on detail about each one of those sites and what the surgery entails and everything, and which one will have. But some patients, like they had, for example, a whiplash, car accident, and then 4 months later, like that was like a year ago, they started having these terrible headaches in the back of their neck. They tried nerve blocks, they tried all those other medications that are helping temporary, and they are ready to have the surgery. It's very individualized. It's a discussion with the patient. It's their lifestyle. It's so individualized at that point. But to go on summary, we will be able to help the patients who have an extracranial cause of their headache. That means there is a pinched sensory nerve that is in the face or the neck, and we have a whole system for identifying those patients.
How can let's say if somebody is at home watching that video and they're like, you know what, I think I might have it. Is that something that they can do at home to kind of test for it?
Definitely. So a patient can follow for over 30-day period. Every time before they have a headache or once they have a headache, they can check those trigger points. And if they find one of those trigger points that is really tender, like I mean it's really tender. Like when I'm examining the patient, they would jump, you know. They would know if there is tenderness. If there is a tenderness, I tell the patients to put their finger on that spot, wherever it is, and take a picture of it. You know, take a selfie with their finger on the spot. You know.
So that tells you exactly where the nerve is compressed.
Yeah, it will tell me if like over a 30-day period or 60-day period, 90% of those headaches were coming from that spot. Then I know that there is a problem there. The problem is, and that corresponds to one of the nerves that we know, then it's more likely than not that the problem is in that nerve and it's not inside the brain. But if a patient have a headache and before and after and during the headache, they press on all these trigger sites that we see, and they don't have any tenderness, so it is more likely than not that their headache is intracranial, coming from inside the brain, and they will not be likely candidates for surgery.
So the surgery would be a waste of their time.
Like with those patients, unless I'm pretty convinced that this is the issue, and we'll talk about it, like when the patient comes in and all these things, how we can be more confident that the problem is in these nerves, and the plan that we make. So when if a patient is listening at home and they know like this is always like it's always in my temple, always this, and they press on those trigger sites and they are tender, what we usually will ask them first to do is a full questionnaire. I apologize in advance that this questionnaire is very extensive, but this is my roadmap to reach the diagnosis. It is 40-something questions. It has so much details. It will ask you to draw your pain. It will ask you to all the treatments, all the history that you have had, the medications that you have tried. It takes time to fill that questionnaire.
Like an hour?
It takes an hour, yeah.
Okay.
Depending on the case, sure. Yeah. But to fill it, like especially with the patients who have had headaches for 20 years, they have so much things tried. So with those patients, they would, after they fill that questionnaire, and that questionnaire I've worked with it for so many years, it gives me a lot of insight for where is the problem. So if they fill the questionnaire and I review it and think that like we have a really good chance, then I'll see the patients, and I always prefer to see the patients if it's during a day in which they have the headache and they have the tenderness. And if I'm examining the patient, I know exactly where these nerves are. I've been doing this for like 8 years, done more than 500 cases, so I know where these nerves. So if the tenderness, let's say we're doing the occipital, I know exactly where it is. If I press in here, it hurts. But if I press like a centimeter to the side of where the nerve is, and it doesn't hurt, it is a great indication that the surgery might work. And then if they have a headache that day and you put 1 cc of local anesthetic, you just inject a little bit of anesthetic next to the nerve. If the pain goes away or improves significantly, they will feel, they're like, oh my God, I haven't felt like this for years. Yeah. As soon as you put like this local anesthetic, then that's an indication that the problem is not inside the brain, it's outside, and we can fix it. And why is that problem there? It is because the nerve is pinched. It's exactly, most people have heard of carpal tunnel syndrome or carpal tunnel surgery. There is a nerve there, it's the same thing. The surgery, the migraine and headache surgery is basically the carpal tunnel of the face. The nerve there is passing through a tunnel that is tight. Why is it tight? Because of overuse in the hand, or it's genetic or whatever. So the nerve is compressed, and then you have pain and numbness and tingling in your hand, and you have weakness, and then you release that nerve and the symptoms improve. If you have those nerves that are in the face and the neck, they are passing through this very similar tunnels, and if they are compressed because you had a trauma, or because it's genetic, or because if it is overuse, or whatever the cause is, and you release that nerve, then first you're going to have a headache because they are in the head, not in the hand, and then when you release that nerve, the symptoms should improve.
That makes total sense. It's kind of, you were telling me earlier on, like, whiplashes and stuff. And
that's correct. We see that like with the occipital specifically. Patients would have had a whiplash. They say like, yeah, I had a car accident when I was 15 and my headache started 2 years later, 3 years later, which is the time for the scar tissue to form, the changes in the musculature. Sometimes it's much earlier than after the accident, and sometimes it's later. Because like when we have a whiplash, for example, the skin is like a leather, it's stretchy. So even though you don't have a cut, but the muscles and the fascia there that are not as resistant as the skin will have an injury. You'll have soreness and stuff like this, and we know all injuries will heal with a scar. And then that scar would make that tunnels and these passages for the nerves tighter, and they will compress the nerve, and then the nerve will be upset and will be inflamed. And since those nerves are coming from the brain, then that inflammation will go to the meninges, which is the cover of our brain inside, and causes inflammation and will cause the headaches that the patients suffer with. And then releasing that nerve will have that nerve healthier, and then will reverse the whole process. I always give the analogy, imagine the brain is a tree, and those nerves are a branch that always catches fire. When that nerve catches fire, the whole tree catches fire. So I'm not fixing the brain. All what I'm doing is that I'm fixing that branch that is always catching fire and making the brain go on all to full headache. And that will make a break in that cycle in which the nerve is inflamed, and it causes all the inflammation in the meninges. Then you have the headaches, and then the nerve gets better for a few days, and then the process starts again, because and we'll talk about the specifics of each one of those trigger sites, how the patient present, how the.
I like the analogy of the tree and the branches, which makes total sense, because patients would feel like it's my entire head, but it actually starts from one place and then the entire tree is on.
That's correct, and absolutely correct. And it's interesting, most of the patients, when they hear this, like the patients who are candidates, and the patients who are not candidates, they would know. They will be like, yes, like anytime I sleep on the back, if they have the occipital headaches, when I have a headache, I can't sleep on the pillow at night on the back of my head.
It's compressing that.
Because it's adding some pressure. Imagine you have like a burn on your hand and you don't want anything to touch it. The patients will say yes, like if they have the one above the eye, like it's so tender I can't touch it, or sometimes I feel like I need to press on it to like abort the attack. And the same with the temple. Like they always start on my right temple or left temple or both temples. And the one with the nose, they say, I had like my nose broken, I have septal deviation, I never fixed it, but like after my nose was broken and I can't breathe from my left side, or like this pain always comes behind my eye. I checked my sinuses, they did all this work up, there was nothing with my sinuses. So all the symptoms will fit into the diagnosis. And the patients who have the intracranial, they would know also. They were like, Yeah, I have my headache. I press here, here, here. There is nothing. Like if I'm pressing now on these nerves, I don't feel any pain, like because I don't have the headaches. But if a patient who have them, they would have already noticed, or they would notice very fast that they have a problem in one of those
I
nerves.
see. If let's say somebody is not ready for nerve decompression,
Yeah.
anything that they can do at home to help or minimize?
So if there are patients who it is obvious that they have a problem with those nerves and they are not ready for surgery. That's correct. And then we will send them for nerve blocks. I do the nerve blocks only for diagnostic. The Botox sometimes can help because the Botox is paralyzing those muscles around the nerves. And when we inject the Botox, some of those muscles will atrophy, will shrink in size, which will give some space. And there are other mechanisms why the Botox is also working centrally, but these are both ways it works. And so there are many other stuff like radiofrequency ablation, nerve stimulators. There are some other modalities that can be less invasive than the surgery, and that will be a discussion with the patient. We will discuss for them the risks and benefits of each one, and then they can decide. That will become a very detailed discussion. You can try this, you can try that. It's always about the patient and trying to help them and try to make a plan that works for them. A lot of patients will feel relieved when they have found when they know where is the problem. A lot of those patients will feel like over those years, because no medication worked, everything, they start like feeling that people are doubting them that they have a headache, because you cannot see the headache. It is, like
They think it's
in their head, and then they have the surgery, and I showed them the picture of the damaged nerve and where it was compressed, from the surgery, and I showed them like the picture of a normal nerve, and they feel validated, like, yeah, I had this problem, and all these years, like, they're crying, and they're like, I have suffered with all of this. I wish I knew that there is a solution that is relatively easy. It is surgery, but it's an hour surgery. It's pretty safe surgery. Patients go home. The scars are very well hidden. And when the surgery works, it's one of the most rewarding for the surgeon. Like it's so impactful. It's very rewarding. You feel, oh my God, like that was great day today. When you see those patients coming in. And we got so many questions over the years. Patients will ask, like, what is the success rate of those surgeries? And in my hands over those years, which is consistent with the national average and the published average, with every 100 patients that I believe they have an extracranial cause, that there is a problem with this nerve, 50% of the patients will have a cure. It will be the best thing ever. 40% of the patient will have significant improvement. They will tell me the medications didn't used to work, now it works. There is a decrease in the frequency of the headaches. I used to have 20 headaches a month, now I have 10 headaches a month. There is the decrease in the intensity of the headaches. They use when I used to have a headache, and that headache will put me out of work. But now I have the headache, but it's not that bad. This is the 40% of the patients. The 50% is it's amazing. Those perfect. We're talking about the 40%. Or they will say that so there is a decrease in the frequency, there is a decrease in the intensity, and there is a decrease in the duration. They say my headaches used to last 10 days, now it lasts for 3 hours. And our patients will come in and they will say yeah, I still have a headache, but I take a Tylenol and it goes away. They are very happy. So that's the 40%. And there is a 10%, which is a significant number, because when I was at certain points, I was doing around 20 a month, 30 a month. Then you have 3 patients who didn't get better. We as surgeons want everybody to get better, So there are 10% of the patients who don't get better. And the reason for that is that we really don't have a full 100% understanding of how the brain works. You know, and the patient needs to be comfortable. Like when the patient comes in and we do all the workup, and if I don't think they are a candidate, there is nothing in the world will make me do the surgery.
Yeah.
The last thing you want to do is somebody who has a headache, you do a surgery and it doesn't work on them. For the patients who, so those are the patients who I don't think they're a candidate, they're not getting surgery.
Basically, out of 10 patients,
yeah,
5 they're going to do great.
Super happy.
4 they're going to have significant improvement.
They will be very happy, but yeah.
Degree. Some is Tylenol,
yeah.
Some is,
that's correct.
And then 1 out of those 10 patients, they're going to have improvement.
They will not get better. You know, and I wish
you can't tell which one is the one.
That's correct, because all of those 10 I was
even though they have like the tenderness on the spot.
That's correct.
Do the injection, the pain goes away, and still they won't.
Still, like there is a 10% failure rate.
Could it be because the compression has been going on for a long period of time? Even though you release it, the nerve doesn't get.
The nerve is damaged, yes. And that's where the complexity and the years will tell us, and more understanding. We don't really understand what exactly happens. We have a lot of information about like how these signals travel to the brain and how they do and all these things, but still like we don't understand the brain 100%, and that's why I think there's still this 10% failure rate in which you'll be like, you know, like I thought this patient is gonna work, and there are cases, in all fairness, in which there are cases. I'll classify the patients into three general categories. There is a category in which I'll be like, the surgery is not for you. I'm not gonna do it. If I were you, if you were a family member, I will not do the surgery.
And these are the people where the pain is coming from the inside.
Inside the brain, like so it's obvious. They don't have tenderness. They don't like these patients will not.
So it's not like a nerve issue compression. It's just coming from the inside.
That's correct. There are patients who are like they are like everything is so fitting the. I would be like, if I were you, I would definitely do the surgery. You know, this is. Everything is fitting the diagnosis, everything, give them the 1cc, they were like, oh my God, I'm feeling that great. Because that local anesthetic will somehow mimic what the surgery will perform.
Yeah.
And there are patients in between. Those are the patients that are in between, in which they had, it is like, those patients, I'll say it's 50-50. You know, it's their choice to do it or not. You know, it's the picture is not super clear. They have different confounding factors. They have an element of a hormonal migraine, tension headaches. They have other stuff that are going on, and I would be like, it's like I cannot be sure, and this is their choice. You know, like initially I wouldn't do the surgery, but with time and gaining more experience and seeing that some of those patients who I believe they are in the 50%, like 50-50 chance, did so well, will be like, okay, like I can't take that away from those patients who are not fitting the picture 100%.
I mean, it's the right, as long as they know the probability.
Exactly.
Right? You're like, hey, 50-50, you're going to get better. Now it's up to the patient to decide
exactly.
whether to go through it or not go through it.
100%. And these are, this is what's about migraine surgery. It is outpatient. It usually takes me an hour to do the surgery. Patients go home the same day. We'll talk about, there are differences between the different sides of the recovery and stuff like that, so we'll not go in general about it. We will
have a dedicated videos for every site.
Yeah.
With what's the presentation, what's the recovery, how is it being done, general anesthesia, local anesthesia, so that if you're at home and you're like, hey, I'm not interested in all the other sites, I'm just interested in this site.
Yeah.
So you're gonna go to that video, and then you're gonna see everything about that site, drains, no drains, all that stuff about it.
Definitely.
Can I ask you a question about, so since last night, actually, in the past 24 hours, we got more than 20 patients interested in migraine surgery, which is a large volume in such a short period of time. And one of the questions are, just looking at the comments people asking is, I had one person, and probably if she's thinking like that, I think so many of migraine patients are thinking the same.
Yeah.
She's like, my doctor told me that this is all experimental and not sure, basically. She's not convinced, or her doctor is not sure that whether that works or not.
Definitely. We get that all the time, So the American Society of Neurology still considers this surgery experimental. The American Society of Plastic Surgery considers this a standard of care. And there is so many research and evidence-based and peer-reviewed paper to support that. And the reason is like any procedure. You think like procedure has been going on for 26 years. It's a very long time. With the history of procedures, it's not a very long time. For the Society of Neurology to say this is standard of care, they need to have all these processes, like everything, to reach that stage in which they say, okay, we are going to believe that this is a standard of care, and that's totally normal. So, like with my own story, when I started doing these surgeries, like 8 years ago. First few patients, they came in to me, and I did their surgery, and they did so well, because initially neurology said like this is, we don't have enough evidence for that, and since then there have been hundreds of papers out and research and more understanding how the surgery works. And then the patient decided still like, I want to have the surgery, and they had the surgery, and they did great, and they went back to their neurologist. And they said, listen, like I have been suffering for this for all this time, and I had the surgery, and really like my symptoms have improved or resolved, and I think that's a good choice. So with time, the neurologist trust and with what we offer have increased, and then there are neurologists that they would be calling me and sending me patients that now, and there are more and more neurologists that they believe it because they see the result. It is, they understand the process that the surgery has to go through for it to reach to be a standard of care. And that's totally valid, all our job is to tell the patients all what we know and all the truth, and they can decide if this is something that they want to go with or not. But over the years, definitely that relationship and that trust between the neurology and the plastic surgeons has improved dramatically. There are many neurologists now around the country. They are in our conferences. They are very pro-migraine and decompressive surgery for a select group of patients. As we said, it doesn't work on everyone. It works on a select group of patients that we have talked about what are the symptoms. And that's the reality of the situation. And it's at the end of the day, it's not up to the surgeon, it's not up to the neurologist, it's not up to the primary care doctor, it's up to the patient to have all the information that they need, and they can decide if they want to do something or not. Our job will be to give as much information as possible.
Absolutely. And all physicians, they want to do the right thing.
Of course.
They want to help their patients.
100%.
And that physician, because we're not taught migraine surgery in medical school.
That's correct.
And even in residency, so it's kind of like evolving. So it's kind of like slowly shifting.
Yeah, because the first 10 years, like there is the proof of concept, and then people start seeing it, and then, oh yeah, like this is something that's actually good. This is the natural. That's the natural evolution and progression of, like at this point, there are thousands of patients that have had the surgery, and it was successful on the percentages that we said, and again, we wish we can be 100%, have 100% result, and these are the data that the patients will evaluate, and they make their own decision. All what we can do is be as transparent as possible about it, and it's just like, for me, if I'm doing a surgery that's not gonna work, I wouldn't be doing it for 10 years. I'll just be doing, I'm a facial aesthetic surgeon. I'll be doing facelifts and rhinoplasties. The reason I do it is that because I feel how much difference it makes, and so rewarding, and I'm very passionate about it because of that, or else like no plastic surgeon will be doing it. few plastic surgeons who are doing it, and they are expert in it. They do it because of real compassion towards it.
Yes, that's how it makes you feel.
Exactly.
And I can see the passion when you talk about it.
And yeah, and moving, like I've been in an academic institution for the last 10 years of my career and just moved to private practice. And if I wasn't passionate about it, I wouldn't fight to continue doing it, you know.
Of course. Last question before we wrap this up. When did you, because when you started, you said in 2018, doing those cases, at some point, because even for you it was experimental at that point.
Yeah, it's just like something new. I like read about it. I want to get the training for it, and I like, okay, like I want to see how that works, you know, because I have always had interest in nerves of the face, and you know, I've always wanted to be facial surgeon all my career. We have been friends for the last 26 years, and you know, like I've always I love everything about the face, and I think the time in which I felt there is like that click is
was
when
like a moment where like that's
yeah
it, or
yeah it's actually in one of the articles it was published about my early patients who would be like it was life changing for them, and you feel like, oh my god, that's like the best thing I've ever, like one of the best things I've done in my career, you know, like I was able to change somebody's life, you know, I was able to have somebody who was unable to like with years I developed a lot of understanding of what patients go through, the headache patients, and all of us have a headache here and there, and every time, like I don't know, on a Saturday I'm like, I wake up in the morning, I have the flu, I have something, and I'm dehydrated, and I'm feeling like, oh my god, there is like my head is hurting. Like I can't even imagine that how some patients they have that. My patients have that like 20 days a month. You know, like how can they function? How can, you know, when you are sick, you have a flu, you have bad headache, you are dehydrated, and you'll be like, oh my god, like this is horrible, you know. And knowing that at this point we have the skill and we have the understanding that we can help. I wish we can help all the patients, but we can help this subset of patients. Is so rewarding. It makes going to work like something. Seeing those patients come to clinic back is it's a joy. It's like, oh my god, that's so amazing.
Well, we appreciate you. Thank you for the knowledge. And if you are thinking about it, check us on the website. The main thing is going to be the questionnaire for you to fill, and then based on that, Dr. Kassis will evaluate whether you're a candidate, whether your headache is coming from outside or it's coming from inside, or at least give him an idea. You know, still have to examine you and to really make sure like where it's coming from. And if you have any questions for us or any other things that you want to learn about migraine surgery, let us know, and we're happy to shoot a video and then explain it back to you guys. Thank you for watching.
Good. We'll see you in the next videos.